when I was given this as a subject, I thought there's lots of things I can talk about. I can talk about schizophrenia. I can talk about bipolar disorder. I can talk about diabetic ulceration. But actually, my background and what got me into all this is dementia care. And I am absolutely passionate about dementia care. The Alzheimer's Society has said that there's about 800,000 people with this diagnosis, and they reckon that in the next 30 years that is going to double. So looking at all you in this room, there's going to be a fair proportion of you with it. So actually, being honest, let's face it, Ellie's halfway there. So I decided to make that my focus, and I think as well the Department of Health, some of you might have seen the document they issued in 2010 about making a difference in dementia, their nursing vision and strategy. So I've kind of tried to link my presentation with some of the principles that they recommended. So this is actually one of my patients, and first of all I just want to ask you a few questions. So you get a new referral for a leg ulcer assessment from a GP for a patient with dementia. What are your thoughts? What are your first thoughts when you get that referral in? Do you think Doppler, dressings, nutrition, holistic assessment, time? Do you think concordance? Do you think, can someone else do it? Do you think, how can I empower them? Do you think, what am I walking into? Do you ever wonder where they're actually at in their illness? Or is it just a diagnosis? Do you know what to say to them? Common types of dementia: vascular, Alzheimer's, Lewy body and frontotemporal lobe. Vascular dementia tends to have quite a sudden onset. And it's really important when you get these referrals come through that part of your initial assessment is to identify what type of dementia does this person have. Because although there are some common features, there are also some subsets that aren't. So your vascular dementia, it has quite a sudden onset. It's linked to transischemic attacks and it's linked to CVAs. You can have a plateau part with it, and then you can have a sudden deterioration depending on what's happening. Alzheimer's disease is more common and it's much more progressive in its nature. Chemical messengers are interrupted within the brain. We have protein plaques developing. Lewy body type dementia is actually my favourite to nurse. It's probably one of the more challenging types of dementia. Again, we have chemical messenger disruption, particularly dopamine, which is how we often see Parkinsonian symptoms with this type of dementia, and it's one of the markers we use for diagnosis on it. The other ones with this type of dementia are, we tend to see hallucinations. Obviously there's the short-term memory loss and confusion, but there's also windows of lucidity, where this patient is then able to understand everything again. And then the last one is frontotemporal lobe. You don't tend to see that so much. You've probably heard of Pick's disease. Many of you will have patients with motor neurone disease or Huntington's disease, and at the end stages of those you do see some frontotemporal lobe dementias going with it. With dementias, the World Health Organization has split it. So they have early, middle and late. When you've got that referral to go and see a patient with dementia, do you actually bother to check the records and see what stage they're at? Because that should affect how you're going to care for that patient, because it'll tell you what kind of problems you might come up against. So if we look at our assessment, things we need to know before we see the patient, things we're looking for. Is there any irritability, anxiety or depression with those patients with Alzheimer's? We know that women are far more likely to get depression than men. So if your patient is female with dementia, do you have that depression screening tool on System 1 or whichever electronic record you actually use? We know that anxiety can affect wound healing because of the release of corticosteroids. Do we look at how that's managed? Vascular dementia, we tend to see more slowed thinking There's a restlessness that goes with it. And again, depression can be a feature of it. Oh, I'm pressing the button, honest. Frontotemporal lobe dementia. You get this repetition of words and phrases and actions. Do you build time into your visit to make allowances for the fact that they will need that extra from you if they are in this phase? There's a lack of logical thinking and we see mood swings. And because it's the frontotemporal lobe, which affects the socialisation element, we can see the difficulty understanding others' viewpoint. Lewy body type dementia, the spatial disorientation, Parkinsonian symptoms, which we've already mentioned, the fluctuating ability. That can affect somebody when you see them as to how concordant they are. Coordination problems. And really, one of the things I remember when I was a ward sister in dementia care was the nutritional deficits we saw with this client group, particularly the Lewy bodies. And although nutritional deficits are quite common with dementia, particularly at the later stages, with this group we used to see such restlessness. In all seriousness, at mealtimes we used to have people parked on corners, nurses, with a plate of finger food to catch them as they went past, to try and get some food into them. So where are we at with nutritional supplements? Do we need some extra support in there? Not just for the wound healing, but for them as an individual. So the common features for dementia is the problems communicating, and we'll look at that in a moment. Hallucinations, agitation, sleep disturbance, pacing, and unfortunately, particularly if there is some frontal lobe damage, aggression. And that's one of the most difficult, I feel. So bear in mind, this is all the stuff you're finding out before you've even gone to your patient. In the NHS, one of the biggest areas for complaint is communication. We're not always great at it as professionals. We need to get more savvy at it with our carers to identify how our patient is, where they're at, what's the best time to visit for their mental health, because that will improve your concordance. We need to be checking their records for their disease progression. Is there any record of their disease progression? Do they have a community mental health worker that you can perhaps contact to find out what their disease progression is? We need to know what their risk factors are, because that might inform our treatment options. If you read back through their records and find that they've had compression bandaging before, but they kept removing it, or they tourniquet their legs with it, or they fell over the bandages where they've been loose, then that's obviously not going to be your treatment option. What's their environment? Do they live alone? Can they record when you're coming? Is there a calendar? All of these things you need to know. And what I was also challenging you with is some self-reflection. I love dementia patients. It's my bag. Not everybody does. Some of my colleagues are actually frightened of dementia patients. Some of my colleagues would rather work with anybody but a dementia patient. So just reflect on your own attitudes towards dementia patients. And person-centred care, which I'll talk more about in a bit. So again, before you've even got to your patient, would you know what their concordance is likely to be? Is it compliance we're going to get from this stage that they're at? Is it a passive acceptance of treatment and care? What have we got? What are you going into? What's the history? The Mental Capacity Act 2005 is one of my big bugbears in practice. And again, you will know what happens in your own areas. You will have seen in people's records what's written. It is really common, unfortunately, to see GPs, psychiatrists, nurses write lovely caveats, lacks capacity. If you look at the Mental Capacity Act, those sorts of things should be decision specific. What do they lack capacity for? Choosing what they're having for dinner? Whether or not they'd like to wear the blue trousers or the yellow trousers with day glow spots? Or whether or not they'd like that dressing or that dressing? So don't accept when you see lacks capacity. It is completely meaningless. If you do have patients where you've gone through a 2-step capacity test, which is very simple and you can do at the time, you may be looking at treatment in best interests. There are times when you will need to do that. If it's big decisions, there should be things called best interests meetings. But how familiar are you with that process for this very vulnerable group of people? Deprivation of liberty. These standards tie very closely with the Mental Capacity Act. And when we're assessing things, part of your competence when you see these patients, when you go out to them, is understanding the whole picture, not just that wound you've gone to see. When you go there, are they in a care home with a recliner chair and it's reclined back? Because if they can't operate that recliner chair, it's restraint, and that's a deprivation of liberty. Do you know what to do? Do you know who to contact? Would you do it? Or would you think, well, I can understand why they're managing them like that, they're a fall risk and they're really difficult? Part of your competence is looking beyond the wound and looking at the whole patient. So, again, before you've even got there, what else is happening with this patient? Are they incontinent? Is it likely that the urine is going down their legs to their bandages? On this particular patient, if you look at the foot, you can see there's pressure damage from compression bandaging. The patient you're going to see, do you need to update their risk assessment? Is this a skin due? Are they delusional? Will that affect your treatment options? Because it often does. But do you know that? Have you actually taken the time to find out whether the stage they're at with their dementia and the type of dementia they've got gives them these problems? So moving on to best practice. You've done your prep. You're there. You're now going to see your patient. Communication. Massive. It would seem obvious, wouldn't it, that we need to communicate well with these people. Simple things. Maximising hearing. If they've got a hearing aid, is it turned on? Is it whistling? Is it in the right ear? Especially if they live alone. Oh, I'm banging it again, nothing's happening. Avoid open-ended questions. If you expect more than a yes-no answer from somebody who's at that end, middle and late stages, it's very difficult for them. It's almost like setting them up to fail. Observe the non-verbals. In mental health and learning disabilities, it's bread and butter for us, non-verbals. I'm not going to insult you as general nurses and other practitioners and say that that's not what you do. You will know how good you are at observing non-verbals and picking up on other things that might be happening with your patient. Are they making eye contact with you? Do they look like they've lost weight? Are they scared? Do they appear to be responding to hallucinations? Do you need to paraphrase stuff? Do you need to mime? What's happening? Have different ways to say the same thing. If the first way you ask something doesn't work, rephrase it into something simpler. Literal terminology. When somebody's dementia is becoming more advanced, it's less likely that the nuances of your speech and communication will be picked up. So you need to make sure that you're very clear in what you're saying. And this is another bugbear of mine. When you go and you see that people are busy talking to the healthcare support worker with them whilst they do the patient, talking to the carer behind whilst they do the patient, and they don't actually talk to the patient. And it could be that you'll have seen these patients and you think, actually, they're talking nonsense. Well, it might be nonsense to you, but it will have meaning to them. So give them the respect, make that eye contact, and listen. Short sentences, simple language. One instruction at a time and face the patient. It can be very difficult if you're having problems processing information to hold on to the first instruction if there's another 3 with it. So don't put too much in. One idea, one instruction at a time. Sometimes if the patient appears frightened, you need a light touch to reassure. But remember what I said about things being taken literally. Be sure that that light touch cannot be misinterpreted. And avoid teasing comments. It's very easy as nurses, I think, when we're trying to cajole somebody to tease them and say, oh, we need to do this, else you won't be able to go out with those dirty bandages. If their type of dementia means they take things really literally, then what that message that you're giving them is, you can't go out. So make sure that you don't fall into that trap. And critically, allow time for processing. Slow your speech down and give the person time to take in what you've said and process it. You might need to give a prompt if you think that maybe they've forgotten, but allow time. Working within the illness, again, you've got people who are agitated. How are you going to deal with that? Is there a time of day when their agitation is less? You'll only know that if you liaise with a carer and you look at patterns of behaviour, but it will improve concordance. Hallucinations. Hallucinations are quite common, especially with some of the Lewy body type dementias, and they can be quite frightening for the person concerned. Sometimes they're not frightening. It can be that they're seeing children playing outside. Children's quite a common one, and they're not frightened by it. But if they are frightened, look at the emotion that's going with it. Look at, are they scared? Do you need to reassure? What is it that they're expressing? Aggression. Unfortunately, aggression is quite common, especially with the frontotemporal lobe. If you're going to look after if you're going to provide care in somebody's house and they're aggressive, I'm afraid I'm of the opinion, step away, do not put yourself at risk. If they're in a care home, there should be carers who will be dealing with that. Do not put yourself at risk. Validation. When I started in nursing in 1988, reality orientation was the big thing. We told people the truth over a 24-hour period. That's okay, I feel, in the early stages of dementia when we might need to be orienting people. They're going home, they need that level. But for people who are further along the disease process, what do we actually achieve? If you've got somebody who doesn't want you to do their bandaging because they've got to get to school to pick up their children and they're 84, and clearly that's not right, what do you do? What do you say? I would suggest you validate them and what they're saying by providing the reassurance, because what is the emotion that they're expressing? It's worry. So provide some reassurance. Routine and order is helpful. And as I said before, allowing time. And in the current NHS, that is really, really difficult when you are given a 20-minute slot to do a leg, if you're at a leg clinic. I think it's about 30 minutes if you're in the community. Excuse me. And that's where I always feel that this is where your courage comes in, that you need to advocate for these patients. You need to be standing up saying, I can't do it in that time. Medication. This group of patients are very vulnerable to the types of medication used. Some of them may be on opiate derivative painkillers, and those opiate derivative painkillers will enhance the sedative effects of certain psychiatric drugs that these patients might be on. That puts them at more risk of developing a pressure ulcer. It's a common theme in RCAs in my own area, people not recognising what will potentiate the sedative effects of what. So all I'll say is if you do have a patient who's on an opiate derivative and they're on psychiatric medication, just have a look in your BNF and see what the interaction might be. Sundowner syndrome. Some of you may be familiar with that. Again, work with it. People with Sundowner syndrome tend to get more agitated as the day moves in to the sun going down, hence what we call it. They can get really quite active, which is very difficult for carers, and they then might not sleep, so they're then asleep in the morning. It is no good you giving them a clinic appointment or going to see them in the morning. So if this is something they have, book your visit for early afternoon, when they're not going to be at that agitated stage, but they'll be awake. Fag time. Of course, as a mental health nurse, I'm sure you can all appreciate fag time. I have patients who won't let me do their dressings until they've had a fag or until they've had a cup of tea. If your patient is like that, build it in, because at the end of the day, if that gives you concordance with treatment, where's the harm? You know, if you're 84 and still smoking, good on you. Is that not the politically correct? Sorry. Sorry, Mrs. Lindsay. We build these things in. That is far better than them wanting a fag or a cup of tea and you thinking, I haven't got time, I've got another visit, because you are under big pressures, and then you have to write non-concordant because they're insisting on that fag. Work with them. Keep hitting this button. So we need to be person-centred. How am I doing for time, darling? 10 minutes. I might start to talk a lot faster now. If I wasn't talking fast enough already, trust me, I can speed up. Joint visit networks. This is something I feel is really, really important, and it's something in my own area, now that we're a joint mental health and community trust, that we've done. Our district nursing teams and community hospitals now all have the contact numbers for our community mental health teams, be it adult mental health or old age psychiatry. Because then, if you've got a patient that you're either concerned about or that you're having difficulty providing the care for, you can then ring these people and see if they're on caseload. Because if they're on caseload, you can look at a joint visit. Could be the patient's deteriorating, and that joint visit will pick up a number of things. But it could really help with your concordance. If they're not on a caseload, they might be able to give you advice on who you need to be getting in touch with. Meaningful choices. Having a diagnosis of dementia does not mean you can't make a meaningful choice in things. It might be a simple choice, but the point is it's a choice. How would you feel if your choices were just taken away from you because you'd got a label? Deterioration markers. Remember what I said about every contact counting. Dementias, sadly, are progressive. Some of them, as we said earlier, like vascular dementia, are sudden. Be aware of that, because you could be the first people to pick up that there is a deterioration. What do you do with it? Where do you take that information? And this is another of mine. Visit the patient, not the wound. Nursing, unfortunately, because of our pressures, has become very task-oriented. We have the wound. We don't always take the rest of the patient in. And with dementia care, you need to really, really take the patient as your whole focus. The wound is a little bit over there. Making every contact count. I don't know if this is a national initiative or if it's just in Leicester. You'd know about your own areas. But basically it's saying it doesn't matter what you've gone to see the patient for. You could have gone for an insulin to give them some insulin. If you pick up something else is happening with them, you signpost it on. You refer it on. You make the fact that your visit was there count. And bearing in mind what I said earlier about the fact that there's a fair few of us who are going to get dementia in older age, personally I'm heading for Korsakoff's. For those of you not familiar with that type of dementia, it's alcohol related. Champion change for quality dementia services. We need to advocate for these patients. They're some of the most vulnerable in our society, and yet they're also some of the most shunned. You know, I'm really sorry, but I actually feel that as a society, some people should be ashamed of themselves and the way they treat these people. We need to really push forward, and we need to have the courage and the compassion and enough to care to say to our managers, I cannot do that patient in that time, and this is why. But if you don't do your homework on their type of dementia, their particular symptoms, how you can best help them, whether they need a fag, you can't do that. You need to do your homework. Challenge poor practice. As a nurse, it grieves me to say this, but it is out there. You will all have seen it, and I'm sure, like me, you challenge it and don't let it go past. I can be quite gobby, as I'm sure you appreciate. And spend an hour in their shoes. What I mean by that is, somebody whose dementia is quite advanced, how much do they actually take of what you've said? If you have a friend who speaks a foreign language, just get them to speak to you in their language for an hour. Ask them to speed the rate up a bit and just throw in the odd word that you might understand. At the same time, make sure it's a close friend, okay? Have them attempt to do things with you. How does that make you feel? I would imagine it probably will make you feel quite disempowered. So how is your dementia patient feeling? So back to my lady again. This one, right time, right place. We made sure her treatment was. So she actually came into the mental health setting. She was quite unwell at the time. Medication support. She was delusional. She actually believed she was Princess Di, which, considering she's dead, I didn't think was that great an option. ABPI review. Obviously essential to look at where we're going with her care. A continence review. She was incontinent and it was running down her legs through mismanagement. Coordinated care. You need the right people involved. So with this lady, we need the CPN involved. We need the district nurse. We need the GP. We need the psychiatrist. And it all needs coordinating. Nutritional screen. Obviously, if you've got somebody with leg ulcers that are leaking really heavily, you are kicking protein out. So what support does that patient need? They might look overweight, but that doesn't mean you don't need to check and give that extra. Antimicrobial soaks. Constant contamination going on with this one. And the delightful pressure ulcer prevention that's dear to everybody's heart. Those of you in the old NHS Midlands and East will know that we had an ambition and now it is our mantra for everything. So your key points that I feel we need to take on board is work with the presenting illness features. So what are they showing you? What can you work with? Make your intentions clear to avoid misinterpretation. A refusal one day does not mean a refusal always. How many times do you see in patient records that so-and-so was refused? It could be, I don't know, a treatment option. But nobody ever goes back and offers that treatment option again because they refused it. So what are your review strategies for things like that? All dementias are not the same. I hope from what I've said today that has become clear that there are things that are different that you can work with if you look. Know how the Mental Capacity Act applies. If you're not familiar with the Mental Capacity Act, yeah, just Google it, read the exec summary. It is really, really important that you know what fits where and how certain standards apply. Around capacity as well, what I would say is there are multiple reasons why somebody might refuse wound care. A diagnosis of dementia is not one of them. Go prepared, do your homework, find out about your patient. Don't go on a wing and a prayer not knowing what you're walking into and how you can best support the patient and how you can best gain concordance with that patient. And finally, conduct that litmus test if you can, even if it's just for 15 minutes, and see how disempowered you feel, because I think if you know that, it will make you more motivated and passionate, as I am, to challenge dementia care and try and improve the practice for when I get there. Thank you.